All right, well, welcome to everybody who are joining us for the molecular workup at therapeutic targeting of H3K27M, DMG, or diffuse midline glioma. I'm Keith Esserick. I am with the Cure Starts Now and the DIPG Collaborative, and I am honored to be part of this. I was asked to be joined part of this by Al Musella through the Musella Group, the Musella Foundation. And we obviously would like to talk a little bit with Carl Koschmann. He is an associate professor and the Chad Tough Defeat DIPG research professor in the Department of Pediatrics at the University of Michigan. He's also the Chad Carr Pediatric Brain Tumor Center Clinical Research Director and the co-lead of the DMG Working Group for the Pediatric Neuro-Oncology Consortium and the lead of the RAPNO Liquid Biopsy Working Group. So with that, obviously, Carl, we want to turn it over to you to give us an update on H3K27 DMGs and therapeutic targeting.
Thanks, Keith. Appreciate it. And Al, this is a fantastic opportunity. And I think the last time we did this about 5 years ago, that ended up being, I think, a useful resource for families and some researchers. But lots has happened in the last 5 years, so we want to give an update with a focus on some of the things that I specialize in from a clinical perspective and also with my lab. So I'm going to go ahead and share my screen. Beginning here. So just to make sure we're all on the same page, I will be talking about diffuse intrinsic pontine glioma. This is the acronym that we start with, which was historically used and still is used to describe tumors that are in the pons, which is the middle portion of the brainstem, take up at least half of the pons and infiltrate. So they're intrinsic to the pons. So they don't have sort of like a focal edge to them. They are integrated into the pons. And so this can be diagnosed radiographically and still is. But this is a clinical subgroup of patients with an average age of 5 to 9, but obviously we see these patients well into adulthood. And it's not that uncommon in pediatric brain tumors, estimated about 10% just for this brainstem. But the prognosis is obviously very difficult for this group with rare survivors beyond 2 years. We'll talk a little bit more later about more updated numbers and prognoses. So again, just DIPG, we're not talking about a genetic definition. Since 2016, we've also had a pathologic diagnosis that includes DIPG tumors, but also tumors in the thalamus and spinal cord. These are all diffuse midline glioma if they are a higher grade glioma, so they're infiltrative. The reason these are all lumped together is that from a behavior and a biology and an origin and a relevant treatments and prognosis, thalamus, brainstem, and spinal cord are very similar. And so we now approach these similar from for a lot of clinical trials now include, DMGs. DIPG, therefore, is a subtype of DMG. And one of the unifying factors of this is, again, still a younger group. As you expand outside of the brainstem, it actually brings the average age up. Our thalamic tumors are found a little bit more often in older patients. Again, we're still talking about young adults for the most part on the higher end, but we do have some patients well into, even older adulthood, but those are rare. So the defining feature for all these tumors is that a majority of them have this histone mutation that we're going to talk a little bit about, H3K27M, which is now you can stain for this with a immunohistochemistry stain and get a result within a few days. And that would be standard that tumors in the midline are stained for this. And then the clinical subgroups are, do you have this mutation or you don't? We're just going to talk for a little bit, what does this mutation mean? And this is maybe the most complex slide I'm going to go through, but we think it's really important. Histones are proteins that are basically the the ball around which all of our DNA is wrapped. And so DNA is the guidebook that tells cells how to behave and whether to remain a precursor-like cell that's dividing or a more mature cell that's in its final state and doesn't need to keep going through cell division and making more copies of itself. But a lot of those decisions, the book is the book, the DNA is the DNA. A lot of those decisions of what parts of the book are read and transcribed into active molecules, the actual functional components of a cell, those are all dependent on what's happening with this protein. And in particular, the histone protein tail is really essential across cancer, but also non-cancer to describe what the cells are going to do. And so there are only a handful of amino acids along this tail, the parts of this protein. The 27th amino acid is a really important one, again, across development and non-cancer, but definitely in cancer as well. And so this mutation of the gene that makes this protein, this is then changed from a lysine to methionine, that ends up having a huge impact because basically you're saying the way the DNA is read is now changed. The reader itself has changed. And what it generally does is it changes the cells that have this mutation to become more like, precursor, baby-like brain cells that are we call them stem-like, and they are more regularly dividing and making more copies of themselves. That's really the core of these midline gliomas, or at least 2/3 of them that have this mutation. We actually think that this is such a radical change for cell biology that not most cells in our body, and these histone mutations almost certainly occur randomly. As cells divide, a random mutation can occur. There's no exposure that led to that, nothing that a young adult or a child was eating or exposed to. It's just the cells divided, an error occurred, it caused that mutation. And if it was in a developing cell in the midline of the brain, that was enough to allow that to be tolerated and turned into a tumor cell. Why do we care? Well, it does change these cells to have this different biology, and we do know that it affects sort of the aggressiveness of tumor, that histone mutations do cause the tumors to be more aggressive, more infiltrative. And this is a survival curve, but if you see the green ones, the patients have shorter survival than the tumors that don't have the histone mutation, the blue or the gray, at least the K27M mutation. We won't get into this, but there's a separate cousin histone mutation that we really do say has very similar biology. I think we've still a lot to learn on the differences between these two, but the histone 3.1 mutation has a slightly better prognosis than the histone 3.3 and is found more exclusively in the brainstem compared to the 3.3, which is found throughout the midline. So historically, the overall survival for midline glioma is very tough, very difficult to survive beyond 2 years. The quoted survival is still around 11 or 12 months for DIPG and 14 months for thalamic DMG. I think these numbers are not completely from the very modern era where we have some therapies that are showing more promise and we have more patients going through multiple rounds of radiation. And so these are important, numbers to be aware of, but they may not reflect the therapies that are available right now. As well, each patient is individual, so it's not prescriptive for exactly how one patient will do. Radiation is still the standard of care, and maybe probably the only universally defined standard of care. Generally, that is a 6-week course of radiation specifically to the brain stem or wherever the tumor is in the midline. Reirradiation is considered in cases, especially brainstem, but increasingly now midline gliomas around anywhere location. If it's been, at least 6 months, ideally from the first radiation, and there was a good response to the first radiation, reirradiation, a shorter course, usually 2 to 3 weeks, is considered. And this is helpful in a lot of cases, and increasingly, considered as at least to be considered would be standard of care, right? To meet with the radiation college and consider reirradiation at the time of progression. So just stepping back, this decision to biopsy, I think historically was maybe a little more controversial than it is now, although it's still difficult for each family when they're offered biopsy and sort of new to the diagnosis and trying to figure out what's best to do for their child. Biopsy is, offered, I think, at almost all children's hospitals in the US and the big children's hospitals around the world. And I would argue, and many of us who are midline glioma researchers, that it is extremely beneficial to pursue it if the neurosurgeon feels that it can be done without additional risk beyond the background risk of doing a brainstem biopsy. So why do we biopsy? Well, we talked about a typical DIPG being, right in the pons, but there are a lot of DIPG cases that are not typical. There may be not purely in the pons, or there may be, don't have a very typical radiographic features. And in those cases, we know that about a third of those actually are not midline gliomas. They're another tumor type. That was published by the group at St. Jude. We found even at University of Michigan that even typical DIPGs, about 1 out of 10 times, are different tumor types. And most of these tumors that we found are high-grade tumors that benefit from radiation, but many of them would have a very different prognosis or treatment regimen for after radiation if you found a different tumor. So as an example, we sometimes see a tumor called ETMR. We've seen tumors that are angiocentric gliomas. These are other, tumors that just would have a very different treatment. We also look for other mutations. We know you might have the histone mutation, but what about the other mutations in the tumor that make your tumor or your child's tumor unique? These are helpful for thinking about which therapy to consider. Increasingly, our clinical trials have what's called a phase 0 component, where you biopsy after you've taken your experimental medicine, and that helps us understand if the drug got into the tumor. And then what about, are there subgroups of H3K27M that have a better prognosis than within the histone mutant tumors? Our group looked at 50 patients who had longer survival with H3K27M, living at least 3 years after diagnosis. And what we found was that they were enriched in a number of mutations in a pathway called MAP kinase. So this is a plot where we're basically saying, in pink are our 50 patients who had survival longer than 3 years, and the black is a larger group of patients that had more, expected survival of, closer to 18 months or less. And what were the mutations we found in those subgroups? And if you see these mutations, BRAF, FGFR1, NRAS, NF1, and KRAS, are seen more often in the longer-term survivors, whereas P53 mutation was seen more often in the shorter-term survivors. And so another group, led by David Castel in France, came out with a paper, and from a different approach came up with the same features of a subgroup of midline gliomas. We think this is probably about 10 to 15% of midline gliomas have these additional mutations and tend to have a better outcome. We don't know how best to treat these. In our own small cohort, they were treated in various ways and still did well. It wasn't one treatment, but we'll need more information to study how best to treatment. And they think they should still be treated with standard radiation and consideration of experimental therapy after. So how do we approach these tumors? How do we treat them? We do the radiation, but then what? And I think right after that radiation, we find that these tumors are often slowed down or stopped. So it's an optimal time to get after them with another treatment. We're going to start by talking about targeted therapies and with a focus on ONC201, which just received FDA approval as the first FDA-approved agent for this tumor. So we're going to spend a little time on that. Then we're going to go into immunotherapy, and then we're going to go into other therapies that I get asked about, quite honestly, is how I organize this. I do a lot of consults for midline glioma cases, and these are some of the questions that come up, and I want to just share what data do we have to support any, sort of suggestions in those spaces. So starting with ONC201, it's a very interesting drug that was designed initially to target dopamine receptors, which are expressed in brain cells, but also upregulated in cancer cells. This was studied as a phase 2 trial in adult GBM, and in that setting, it was found to be safe and blood-brain barrier penetrant, which very few drugs are, but very few to no responses in the adult GBM world. However, there were younger patients on those early trials that had the H3K27M tumor who did better than expected. And without having a clear understanding or mechanism as to why that was the case, Sharon Gardner from NYU led a multi-site phase 1 trial with including our site and a few others to see if there was a safety and efficacy and early efficacy signal in the H3K27M patients. While that trial was ongoing, a separate paper studied this drug and found that it has an additional mechanism of action where the drug also enters the cancer cells and opens up a protein in the mitochondria. That's the gas tank of these tumor cells. And that opened protein, this CLIP-P protein, starts to basically wreak havoc on the mitochondria and starts chewing up functional proteins. And so it really impairs the ability of the mitochondria to work. And our group and others have shown that this is probably the more important mechanism of action for how this drug is working in K27M cells. So the next slide or two is going to be about that mechanism, and it is a little science heavy, but I think it's important for understanding why this drug might be working in this tumor cells, and also where do we go from here? Like, how do we build off that? And so I'm just going to try to hit the science, but not make it too dense. So we did a thing in collaboration with my colleague here at University of Michigan, Dr. Sriram Vanetti, where we studied in tumor cells in the lab, when we treat them with ONC201, what happens to the metabolites in the tumor cells. And basically, a lot of the metabolites that are used to create energy are massively affected by giving the drug. And the cells lose the ability to have active synthesis of glucose to be able to form energy that the tumor cells need. One of the things that's interesting is that as glucose synthesis goes down, another type of metabolite synthesis goes up, and that's glutamine. We see these glutamine pathway metabolites go up. This is another source of energy that cells use, and especially cancer cells. One of the pathways this glutamine metabolism can lead to is a metabolite called 2-HG, and specifically L2-HG. And we found that it was up in these treated tumor cells. And then we actually looked back at our patients who had gotten ONC201, and the patients who had done well with ONC, who had had a better than expected response, had also increases in this L2-HG in their spinal fluid. This is a research grade test, so not something that's quite ready for clinical, but it did help us feel like this was an important pathway in these cells. And what we did then was to look at what this was doing to a really important marker in these tumor cells called H3K27-trimethyl. So this gets confusing here, but in our H3K27M mutant tumors, the overall amount of methylation at that 27th amino acid is lower. And that's because the mutation itself is inhibiting enzymes that are able to adjust that trimethylation across all of the nucleosomes. So it's a really key feature. And if you see across these three cell lines, it's a low amount of trimethylation. That's what these tumor cells need to keep behaving poorly, basically. And when we give the drug across these cell lines, we see that that's restored to a high amount. And that's actually what normal brain cells look like. They have a higher amount of this trimethylation. So we wondered, is that the case in our patients? This was sort of the ultimate test of the drug. And in patients who had received ONC201, but had unfortunately passed away eventually, when we looked at their tumors at autopsy, this is what the brain normally looks like. The midline gliomas with the histone mutation for this mark, very low. That's how you diagnose this tumor. But if they had gotten ONC201, the trimethylation was closer to normal brain. And we saw this across all of the tumors that we looked at, as well as at another site that also had autopsy specimens. The longer you were on ONC201, the more that trimethylation was restored. So this was really important feature to tell us this drug was restoring this basically taking away this feature that was really part of its malignant phenotype. How does that tie back to the 2-HG? Well, L2-HG, which is metabolically increased in these tumor cells, actually inhibits another class of enzymes called demethylases. And we showed in a number of ways that it was the L2-HG that was causing that change in the trimethylation. So complex concept. Let me try to pull it together with this figure. ONC201 is going into the mitochondria, disrupting the ability of your mitochondria to create glucose-based energy for the cell. But that leaves a hole for glutamine to kick in and make this L2-HG. That inhibits this protein that basically turns up the trimethylation and makes the cells less stem-like and more differentiated like normal brain cells. So ONC201 sort of having this metabolic and epigenetic phenotype. It's very specific in our H3K27M tumors, and we think this explains why this patient population might be doing better with it. So how are the patients doing with it? Well, to date, we have a bunch of small series of phase 1 and 2 data and an ongoing phase 3 trial. The drug company took some of the recurrent phase 2 data from patients with recurrent thalamic DMG and submitted it to the FDA to say, listen, this is an extremely high-risk patient population, patients with H3K27M tumors that have already grown, but they saw a signal where 20% of them had a radiographic response, right? And so that's shrinkage of the tumor by, at least 50%. And when they used features of radiographic criteria that included some newer criteria that they and a lot of us in the field feel better recapitulate how you measure response in midline gliomas, that response rate was closer to 30%. So obviously not a home run, but enough of a hit that they submitted the data. They also submitted the mechanistic data that I just showed. And that was enough for, in August of 2025, the FDA to, after their review, grant accelerated approval to ONC201, now called Modeso, which would be the first approval in this midline glioma population. So what does this mean for the field? And I think that's a lot of the reason why Elle and Keith and I decided this is a big inflection point for the field. What do we do with this information? So as a positive, this is a huge step for patients with this tumor to have a drug that's approved in the US that can be prescribed now. You don't have to be on a clinical trial. If you have a recurrent H3K27M-DMG, your insurance likely will approve the prescription of it. And that opens up a lot of opportunities. This comes from clinical data that is certainly promising with a small portion of longer-term survivors. And the mechanism of action is very specific to this tumor, and it's on target to these tumor cells, and it's very well tolerated. I think across these studies, what's not, at all debated is that these patients do very well with this therapy. It's taken by mouth once or twice a week. So these are all big steps for the field. But what are the gaps in knowledge and where do we go from here? So this clinical data that was reviewed is really a small group of patients that have been treated with ONC201, and it doesn't have the more later phase type data that might normally be needed for an approval. So it was from recurrent thalamic patients from pooled studies. It's also, it's an accelerated award, which quickens the pace at which it's approved, but it's contingent on additional larger prospective trials, including trials where it's patients that haven't yet had recurrence. And there's a study called Action, which is still ongoing outside of the US. So we need to see the results of those to see what is the total signal, and is this done in a larger and more rigorous trial where patients are all treated the same way. And in this trial, actually randomized some patients not getting the drug to be able to most effectively understand whether it's working. And then I think just moving forward, we need to figure out which patients, what are those patients that are going to do well with ONC201s that we should be really trying to get them on the ONC201 earlier. And if there are mechanisms of resistance, how do we build upon that? So that's a big focus of my lab. We found in a cohort of patients treated on the early phase studies that the strongest marker of resistance in that data set was mutation or activity in a pathway called EGFR. Basically, the patients at U of M who've had EGFR mutations, this would be a second mutation on top of the K27M. We have yet to see a patient with an EGFR mutation respond well to ONC201 by itself. These are small series of patients, so they're mostly just generating ideas rather than definitive truth that no patients in the future may ever respond. But it does give us a signal that there may be something about EGFR and resistance. And in fact, the adult group, when they found that the ONC201 didn't work well broadly, they found that the more EGFR the tumors had within those adult tumors, the less likely they were to respond to ONC201 clinically and in the lab as well. So a future direction for where do we go with ONC201 and a cousin ONC206. There's a lot on this slide, so I'm going to sort of walk you through this. One of the platform trials that I'm involved with, along with other clinicians from PNOC, the PNOC consortium, is PNOC22. And this is a platform trial where drugs can be combined. And so far, a lot of those combinations have been ONC201 based. So in that trial right now, if you have a PDGFRA mutation, you'll get ONC201 with avapritinib. If you had a BRAF V600E mutation, you would get ONC201 with dabrafenib and trametinib. And if one, you'd get a MEK inhibitor, FGFR, or erdafitinib with an FGFR inhibitor. So it's sort of building this idea that can a second drug that's targeted to your tumor mutation sort of build on the potential success of ONC201. And avapritinib is a drug that our lab and some colleagues published on recently that does show really promising efficacy in mice. We showed some anecdotal data from some patients responding. We know it gets into the brain. And so this combination with ONC201 may be particularly promising for those that have this PDGFRA mutation. What about combinations for resistance pathways? Things that my lab and some collaborators are working on is an EGFR inhibitor broadly for midline gliomas, if that resistance pathway is important, or maybe in particular those with EGFR mutations. CBD, which we'll talk about in a second, to target a pathway that we think may be involved in resistance. And then this idea of sequential therapy that we use in other high-risk cancers like neuroblastoma, where you would do one block of therapy, and then you would do a different type of therapy, not waiting for progression to occur. PNOC23 is another trial, which is a phase 1 trial of ONC206, which is a modification of ONC201 that was generated to make ONC201 get into the cells better, get into the brain better. But we've also found, and other labs have shown, that it's actually a stronger drug, even sort of taking the blood-brain barrier out of it. So the goal dose is still being determined in this phase 1, and a future phase 2 will be needed to confirm if there's efficacy in this. Sort of moving forward and thinking about immunotherapy, which has clearly advanced a lot just in the last 5 years. We'll start with CAR T. So CAR T is chimeric antigen receptor T cells. These are taking T cells from the patient, modifying them, and then giving them back to the patient, modifying so they find the tumor and kill the cells in the tumor. And the very early studies, these were done through injections of the T cells in the blood. Now they're almost all done, or maybe all done, by injections in an Ommaya catheter that drains the T cells into a ventricle and then drains over the tumor. And Dr. Monge from Stanford and Dr. Vitanza's group from Seattle have shown in some series from these early phase 1 studies that a small group of these patients do have radiographic and clinical response. And some of the responses in DMG are actually quite quicker than we've seen, for example, with ONC201. A lot of patients in these studies and in my experience co-following these patients don't have a sustained response to CAR T, and so the current experimental trials are building on the early success of CAR T. So these are some of the active trials going on right now, and really there's 2 ways in which trials are making big changes right now, and this is a moving target, so the things that they're working on may change with each year. But right now, a question is, should you give chemotherapy systemically prior to the T cells to help reduce the immune system that's in the body to let the body tolerate the T cells and let them work without obstruction. And so that's done at some of the trials for CAR T and not all of them. And we'll hopefully figure out whether that's important over the next couple of years. The other is, what is the target? Is it a single target? Is it multiple targets? That is still a question. And so all of these trials are building off previous models that showed some success. This is the CAR T trial that's open at the University of Michigan. It was established at City of Hope by Leo Wang's group and the adult group there. And so just to give you an example of how this might work, patient would get their T cells collected. Those would be then manufactured in a lab to generate the ability to find this IL-13Ra2 protein in tumor cells. Then you get chemotherapy. You're admitted in the hospital, get chemotherapy for a week, and you get weekly infusions in the Ommaya catheter. And then at the end of that month, you can then move on to continue to get these infusions as long as there are T cells remaining. And the schedule is a little bit more ad hoc, but you don't get chemotherapy in those subsequent cycles. Another immune therapy that caught a lot of people's attention is this DNX2401. It's an oncolytic virus. So just like we have viruses that cause infections, these viruses are actually capable of infecting the tumor cells and have been modified in a way that they are selective to the tumor cells. And so they kill the tumor cells. And not only is that useful as a therapy in itself, they release inflammatory markers to encourage the immune system to come in and continue to kill the tumor. This is very effective preclinically. And Dr. Alonso from Spain did a phase 1 for this with 12 patients and showed an early signal for safety and efficacy. And so now this will be moving into clinical trial in the US and into Europe, where patients will have the opportunity at a few PNOC sites to get a virus injection at the time of biopsy, and this would be after radiation, and then continue to get separate virus injections, whereas the phase 1 was just a single viral injection. So all of these would be with the patient asleep in the operating room to see if there is improvement in outcome. Just moving back to the last topic of treatments, how do we make our treatments better? You may have heard of the concept of focused ultrasound. The idea here is the blood-brain barrier is this restrictive layer around our blood vessels in the brain that doesn't allow bigger drugs to get into the tumor at all. It basically remains in the blood vessels and then is washed out of the body. So an example would be doxorubicin. It works very well against midline glioma cells in a dish, but it doesn't at all get into the brain without some manipulation of the blood-brain barrier. So the idea of focused ultrasound is to actually use a machine to give high amounts of energy, of this ultrasound energy, to be able to disrupt the blood-brain barrier and allow these other treatments to get in. In some cases, the ultrasound itself is actually therapeutic in and of itself. So these are early phase studies. Some patients with DIPG and DMG and other brain tumors are being treated with this. The current focused ultrasound machines require a huge amount of investment in infrastructure. And so there are also some companies making more like portable ultrasounds so that this might be able to be rolled out more. Still no efficacy data on this yet. So it's still in early phase. This was a paper that caught a lot of attention out of Samir Agnihotri's lab in Pittsburgh. And this is the paper I look to when families say, is there something in the diet we could do? And the reason why I pose to this paper is it's the only paper at a high level that has manipulated diet in mice with K27M tumors and shown that it can affect the growth of the tumors. And what Dr. Agnihotri showed was that if you took all of the amino acids, so there's 20 amino acids in proteins, and if you took each one out, it was really only methionine that slowed the growth of these tumor cells. He sorted out a mechanism that helped explain that, and then he fed his mice the same diet but without methionine, and that by itself was able to slow down the tumors. Practically, this is much more complex in patients and is very unclear exactly how we're going to be able to study this. Methionine is ubiquitous in the diet. It's in meat, but it's also in a lot of non-meat. And it's very hard with diet alone to just be able to restrict from any sort of oral diet. There are methionine-free formulas, And so one idea that we may consider in a future trial would be a methionine restricted formula for patients who are already using tube feeding. Still early stages, not yet ready for prime time, but it does show the possibility of diet helping. Keppra is also something that is capturing a lot of attention in the field. Dr. Monge from Stanford has shown that the neurons that these tumors infiltrate into the normal brain, there are neurons there, the normal healthy neurons that are signaling in the brain and are electrically active. They form synapses with our midline glioma tumor cells and support the tumor cells. This is called sort of neuron to glioma synapse. And what Dr. Monge showed in a preclinical study that was published this year, that giving Keppra, which helps reduce some of that electrical activity, can slow down the tumors. And in unpublished data that I'm showing here, when our group and Dr. Monge's group have looked at our patients who have received Keppra, they do a little better than those that haven't. This is retrospective data. We would need to study this prospectively. But it is something where if patients are at risk for seizure, being on Keppra may be something that potentially could be part of a treatment regimen as well. And then finally, cannabidiol. This is something that got asked so much and actually was previously supported research by the Cure Starts now. Can cannabidiol help slow down tumor cells? This has been asked in a lot of cancers. One of the things that we found, and this is in collaboration with a former lab member of mine, Dr. Yadav, who now runs his own lab in Kansas City, is that there's a transcription factor in brain cells and developing pontine cells that is upregulated in tumor cells called IT1. And it's been known for a while that CBD does suppress IT1. So we focused on that. And what we found was that if you give CBD, which is the non-psychoactive component of marijuana, it can slow the migration of tumor cells, and that's through targeting of this IT1 and through a couple other mechanisms. But then it really requires higher dose CBD, and that's how CBD is dosed for patients who have seizures that are controlled by a synthetic form of CBD called Epidiolex. Of note, this may impact the metabolism of other drugs, and it also may suppress immune system. And so if you're on a clinical trial, you obviously would want to talk with your provider about how and whether it's safe to use CBD alongside your other therapy. And then finally, just to wrap up the talk, what are we doing to track response to these promising therapies, right? So we have better therapies than we did 5 years ago, but how do we know if it's working? And any of you who are watching this who has looked at an MRI with your clinician, or you're a clinician looking at an MRI with your patient, it's very disappointing at how much we still need to make progress on monitoring these tumors. So tumor DNA is low-hanging fruit. It's debris that comes out of these tumor cells. It's very enriched in the spinal fluid. We developed an assay here where you could look in the DNA of the spinal fluid and find a lot of molecules that had the histone mutation, and this is molecules that didn't, and then you could create a ratio. This is using a machine called ddPCR. So we published on that. The Memorial Sloan Kettering group has published an adult GBM that when they sequence spinal fluid from adult GBM patients, just having tumor DNA sequenceable was in and of itself a poor prognostic find. So it might get used in that way. A former clinical fellow in my lab, Evan Cantor, who's now at Connecticut Children's, did a study where we looked at patients treated with ONC201 at a serial checking on spinal fluid as well as plasma. And what we found was that when you looked at spinal fluid, the size of the tumor did not correlate with that percentage of mutant DNA of the K27M. But that if it changed over time, if you had a high level at the beginning and a low level later, those patients did do a little better with this therapy. So that was an indicator that this might be an early prognostic tool. And we also saw that to a smaller degree if we looked for the same DNA in the blood, which would obviously be logistically easier. But the amount of DNA in the blood is much less common in the, and so it's a little bit more like a needle in a haystack, whereas the spinal fluid, you've got many needles in that haystack, if that makes sense. So what do we do with this information? So one might be that's dropping, that might have a prediction of improved prognosis and longer time, longer survival. But also in a case by case, what we can sometimes do is say that if that amount of the mutation goes up, oftentimes that preceded the MRI about to get show radiographic progression. So I just use this as a case example. This is a patient with midline glioma, and the gray is the tumor size over time. You see that started on ONC201, tumor size was getting better. We were reassured, but unfortunately at that same time, the plasma allele fraction of K27F was actually going up, and the spinal fluid was going up as well. And unfortunately, that did precede the tumor growing at the next MRI. So if we had these tests at clinical grade and usable in real time, we would maybe be able to say, listen, let's not wait a full 2 or 3 months for the next MRI. Let's watch you a little closer, maybe get sooner MRI. How might we move this to clinic? So I'm working on this test and just received an NIH grant to move this test into the clinic and make it what we call CLIA certified so that it's consistent enough to be able to trust the results. And what we, in testing this, we're basically creating a model where, this might be the allele fraction in the blood if this test is working really well, where it's high at diagnosis, you get radiation, it drops down. And then for a while, that test may be negative in the blood. But as it starts to creep back up, that might be a time to start watching the patient a little closer. We still need to figure out if this is a reliable enough test through this CLIA validation process to be able to start releasing these results. And then ultimately, you would need to run a clinical trial where you give those results to the family and clinician and say, what did you do with that information? Did it cause you to get an MRI sooner? Did it cause you to change treatments? And did that affect the outcome? So we're getting closer to this, and this feels extremely slow to families who read these research papers and are ready to do this. But we are getting closer, and we're working on turning it into clinical grade. And then finally, we talked about metabolism, metabolites. Can we use metabolites in the spinal fluid? This 2-HG we touched on earlier, for patients that had increased, we saw better responses to ONC201. And then here's a patient whose CSF 2-HG went down, and they didn't do well with ONC201. We've been recently looking at this in this PNOC22 trial, and we do see that these same glutamine-based pathway, if you see a change in upregulation of glutamine pathway metabolites, that correlates with overall survival in patients being treated with ONC201 and paxilicib in this case. So again, a couple steps more away from being in the clinic, but this metabolite analysis we do think would require spinal fluid and not the blood from our early tests. So obviously just covered a lot there, but all of this more or less is new information from the last time we did this presentation 5 years ago. So it shows how quickly the field is changing. And obviously the steps that we're making, we still have a lot of steps to go, but I'll stop there and thank all the people in my lab, our collaborators, and our funding sources.
Well, thank you very much, Dr. Koschmann. I know we have some questions that have been placed there in the chat there with it. I can go through those with you if you can maybe help us out with some clarity. I think some of these you may have answered in an indirect way, though. One of which deals with more of a case study, and somebody who's asking that there was a pediatric DMG patient who's been stable for years and on ONC201 through expanded access, but now that the drug has been approved, the doctors are recommending doubling the dose to match current protocols. Do you think that increasing the dose would be beneficial? And do the potential advantages of increasing the dose outweigh the potential toxicity?
Yeah, so let me just make sure that so you have a patient who was treated with ONC201 for a long period of time, and then the tumor grows on ONC201. Is there a benefit in increasing the dose of ONC201? Is that the short of it, Keith?
Yeah, I mean, we don't have anything that
No,
necessarily says that it's expanding. It's grown. It's more of just to match the, yeah, correct, to match the new.
If you have the ability to go up, should you go up?
Correct.
So The initial phase 1 of ONC201 it got to the recommended phase 2 dose pretty quickly, and that's what's still used routinely, which is really a weight-based approximation of what's used in the adults, and it's a once a week dose that at most is 625 milligrams once a week, and then it's weight-based down if you're under 60 kilograms. This question that comes up is, why do we only dose it once a week? Let's just start with that. And then separately, is there benefit to increasing? Is it safe or beneficial to go up on the dose on that single day, or maybe do a second day in that week? And I will summarize by saying we don't yet have efficacy data to say that anything beyond that once a week dose that we started with is better. It's not to say that it won't be, it's just that we don't have that data, so I can't confidently comment on it. There was an arm of the phase 1 where patients were treated 2 days in a row, and that was published, so I can comment on that. That was safe in that cohort to use it 2 days in a row. And what they did found when they looked at blood levels of the drug was that, and this was maybe how this was designed and what the hope was that there's a peak of the blood after the day 1 that hasn't yet gone to 0 by the time you give the dose on the second day. So the peak on the second day is even higher. And so the hope there is that you're getting more into the tumor. So that sounds great, but more drug is not necessarily better if it doesn't lead to outcome changes, and we don't yet know. The phase 3 trial does have this: a third of the patients get the drug 2 days out of the week, a third get it just 1 day, and a third get it not at all. And so hopefully we'll be able to answer that there. The actual FDA approval is for the once a week approved dosing. The question is whether you could, from a prescription and insurance approval, get the twice a week, and that's variable in practice. It's very early to know, how clinicians are actually using it. So I don't know. That's probably fully answer the question, but that's the most amount of information I have on the topic. Oh, Keith, you're muted.
Thank you. I know you talked also about the various combinations. I didn't hear one, maybe I missed it, about a possibility of ONC201 and ONC206, and one of the questions was about if there's any plans for them.
Yeah, so it's actually not an intuitive combination. It's a drug that works the same as the first drug, but maybe a little bit more brain penetrant, as we understand. But Dr. Nazarian, one of my collaborators from Zurich, combined the two and published in neuro-oncology in mice and showed that they can work together. And in fact, where this caught a lot of attention is that the German ONC201 Forever was being manufactured by a physician in Germany outside of the drug company, and he was prescribing both together, I think based on the results of that paper. I will say that it's not an intuitive combination to me, and I don't think it's going to be one that we will focus on in our platform-based trials. I think anecdotally from a lot of patients I managed who were getting ONC201 from the German physician, we didn't see an additive toxicity, but it's well short of knowing. It was not a clinical trial, and so it's well short of giving that as a recommendation. For me, the future of combination, if we, for ONC201, will be different mechanisms of action, not just a drug that gets into the brain a little better, if that makes sense.
Okay. Well, and in that same line of questioning, what about everolimus? Has that been suggested?
Really good question. And everolimus has gotten a lot of attention in Europe in particular. The studies led by Jacques Grill through the Biomed program have shown a small signal for everolimus being broadly effective in ONC201 or broadly effective in midline glioma. And the studies right now are testing ONC201 compared to everolimus. So we'll get a little signal there, but then a lot of families say, why would we not just different mechanisms of action, combine them together? I think it's certainly a reasonable approach. Everolimus targets a pathway called mTOR, which is broadly active in midline gliomas, but it's not what we would call a classic precision medicine target, where we see a lot of mutations that are directly targeted by everolimus. It's a drug that's used in a different brain condition called tuberous sclerosis, where in those patients, the everolimus is more closely providing a sort of precision medicine approach to the mutation seen there. And so I think that we know how to use it in kids. We know that it gets into the brain to some extent. We can follow levels for it. I think it's certainly worth studying, but it's short to me of saying patients should broadly start combining this without clinical data to support that just yet.
Yeah. Well, I know we're seeing some parallels with it with like some of the Connect trials and things along those lines that are suggesting that it's worthwhile looking at, but obviously you want to test it out first.
Yeah,
Um,
maybe Keith, I can make a comment. The Connect trials are another fantastic platform-based clinical trial that uses this sort of platform trial to get at precision medicine approaches for midline gliomas and other high-grade gliomas. And
you're talking about the target variant
the
variant
targets, yep.
of Connect, yeah, because within Connect, obviously, there's that's a whole consortium in and of
Sorry, the
itself.
target trial within Connect, you're right.
Yeah.
And one of the first arms to open in that is ribociclib and everolimus for
Yeah.
tumors that have both PI3 kinase alterations or cyclin-based alterations. And so that'll be another place in which we'll see if there's a signal when we target specifically patients' tumors that have pathway type alterations. So I really do prefer that approach, which is more patient specific for these precision medicine therapies, rather than all patients getting something like an everolimus. That would be at least my recommendation of where we go as a field.
Well, and it's good for the patients, but it's also good for the accruals because this is such a rare population, and so we have to make sure that we do that service to the parents, the patients, and also to the science. So, I have a question in particular that has to do with the access issues. I mean, obviously, we're focused a lot on the DMG aspects of this review. But for patients that are not in that realm, how is their accessibility with ONC201? Has that changed at all, or is it still through a clinical trial? Has that opened up doors at all with the new accelerated approval?
So one of the things that midline glioma patients and providers are very familiar with from never having a drug approved is that once a drug is FDA approved, it's in shooting distance of being prescribed. Any oncologist can prescribe it, and any clinical, oncology-based pharmacy can fill it as long as the insurance company approves it. And this is really the U.S. health system that I'm talking about here. It's going to be different by different international countries. And so for years, we have been doing precision-based treatments for midline glioma on and off trial where we prescribed FDA-approved drugs for other indications. Maybe it's an adult solid tumor indication or an adult leukemia indication, but the drug is available and prescribable, and insurance companies often will approve those for midline glioma. So now we have this drug that has FDA approval for recurrent H3K27M-DMG, and it does give the power into the clinicians' hands and families to consider using it outside of that realm, whether that's upfront with midline glioma or after initial radiation, or in combination with other therapies, or to maybe the question you're asking, Keith, is outside of midline glioma. Might you consider it for another, pediatric?
Correct.
So it really comes down to that clinician and that patient and that insurance company. It's not going to be a broad approach, but it is going to probably be used in those settings. And we're really short of knowing what is the right time and place to use it, other than it does give more flexibility to that patient who might be from a remote area. Maybe they don't have the means to travel for a clinical trial. If they and their clinician feel that it's a good fit for them, there is more flexibility there.
Okay. All right. That should be the completion of what I see in the chat window there with it. Al, was there any other questions that you had?
Hi, yeah, there was one. You mentioned the effect on mitochondria. Is that the same in normal cells, or is it more so in the tumor cells? This was
Like-
with ONC201.
Could have an effect on normal brain cells? Is that what you're asking?
Yes.
So it's a really good question. And I think it's actually a surprise to those of us studying the tumor when we learned of that mechanism and studied in our tumor cells that it was not more toxic on normal brain cells or other, that patients weren't having more side effects. The short answer is there has not been a really comprehensive study of the effect of ONC201 and ONC206 on healthy cells. I think some of those papers will ultimately come out. But it is, if we look at how ONC201 has done in early phase studies from a safety perspective, it has really outpaced almost every other therapy we've looked at, which generally do have some off-target effects. When we think about precision therapies, a lot of tyrosine kinase inhibitors that we've prescribed, those do target the tumor cells, but then they also target the GI system and the skin. And so we do see some off targets. And obviously, it is a feature of ONC201 that it doesn't have this. One might expect that it would have this effect on the mitochondria in healthy brain cells, and that one of the things you might see from that is fatigue or headaches or some other CNS type symptom. And we do see that to a very small degree, but really most of our patients notice no side effects in my experience. And so I think that a lot of the impact that's specific to K27M cells, and this is just hypothesis, is the K27M cells need their gas tank going at full. They need a full gas tank to be able to keep up with all of the processes, and that's why they're so sensitive. And maybe the resident brain cells are a little bit more tolerant of having the gas tank be irritated for a short period of time. The other piece is that epigenetic piece we talked about, which is very specific to the K27M cells, and those normal brain cells are going to be less affected by that. So it's a great question. I think it's still something that's understudied, but for now we have a drug that's pretty well tolerated. I mean, very well tolerated in our patients.
Perfect. Thank you so much. It was a pleasure having you, and we'll see you next time, another 5 years.
Yeah, 5 years from now, we'll see where we get. Thanks,
Hopefully we have a session on just curing it. That'll be the next one.
100%.
That'd be nice.
All right.
Okay, good night.